I'm Dr. Robert Jones, and this is the introductory lecture for the Focused Lower Extremity Compression Ultrasound module. DVTs affect approximately 2 million people per year in the United States. Now, the signs and symptoms of DVTs are nonspecific, and this is problematic since the feared complication of a DVT is pulmonary embolism, and this will occur in about 50 to 60% of untreated patients with a 25 to 30% mortality rate. So it's essential that we accurately diagnose these people. So the focus question for this module is, does this patient have a DVT? Here you have a patient who presents with unilateral right leg swelling. In this module, we're going to teach you how to approach a patient like this. Through early diagnosis of the DVT, this is what we're trying to prevent, the pulmonary embolism. And here you have a patient who has a large central clot in the pulmonary artery that came from a blood clot within their leg. The focused lower extremity compression exam that we're going to be teaching here is going to be from the groin through the popliteal vein where it trifurcates. Color Doppler is not going to be required, and augmentation is not going to be required. But you're going to be scanning from the inguinal fold down to where the popliteal vein trifurcates. So first point to remember is that since we're only scanning from the groin to the popliteal vein, we will not be excluding isolated calf DVTs with this focused study. So I want you to keep that in mind early on, that ruling out isolated calf DVTs will not occur with this study. So this then leads to the question, should we scan the calf veins? Some studies have shown that there's a 20 to 30% propagation rate of isolated calf DVTs, and that there's about a 5% risk of developing pulmonary embolism with isolated calf DVTs. However, there's a 4 to 10% risk of potential bleeding while on Coumadin. So a lot of this will boil down to if you're at a center that does treat isolated calf DVTs versus a center that does not treat a calf DVT and would only treat a DVT if it was from the popliteal vein and proximal. So what are the cons to scanning the calf veins? Well, it's more technically difficult to do, and the accuracy is much less in the calf veins as opposed to the proximal veins of the lower extremity. Secondly, isolated calf vein DVTs are rarely treated clinically. And number three, a viable option is to perform a serial exam of the common femoral vein through the popliteal vein in medium to high risk patients 72 to 96 hours. So this is an alternative strategy that is frequently employed at a lot of major medical centers. Bottom line is you want to follow your institutional guidelines. If you're at a center that treats isolated calf DVTs, then you really should be imaging the calf veins. If you're at a center that does not treat isolated calf DVTs and you're just scanning from the popliteal vein from the common femoral vein through the popliteal vein, you still have to remember that about 20 to 30% of isolated calf DVTs will propagate proximally. So it's important in the medium to high risk patient that you have them rescanned 72 to 96 hours later if their first proximal DVT scan was negative. Should you scan both legs? If both legs are symptomatic, then you should scan both legs. However, if only one leg is symptomatic, then you do not have to scan both legs. However, if a patient has an extensive DVT in the symptomatic leg and you cannot find the proximal end of the blood clot, then I would recommend scanning the other leg. Lastly, do you need to perform color Doppler? The mainstay of diagnosis of a DVT centers around the sonographic appearance of the vessel lumen and the compressibility of the vessel. So in this focus study, we are not going to be emphasizing the use of color Doppler. I'm Dr. Robert Jones, and in this lecture we're going to go over how to perform the focused lower extremity compression ultrasound exam. Let's first look at some exam essentials. First, you're going to use a 5 to 10 megahertz linear transducer in the thin to average adult However, in a larger adult, you may need to use a 2 to 5 megahertz curvilinear in order to get the penetration that you need. In terms of positioning, you want the patient to be comfortable. Ideally, you should have them in a reverse Trendelenburg position with the leg externally rotated. In older patients who can't externally rotate their leg, you may want to have them turn on that side so that they're not tensing their leg. When performing compression of the vein, it's always going to be done in the transverse plane. Here you have an image of the proximal common femoral vein, so your anterior, posterior, patient's right, patient's left. You can see the compression of the common femoral vein here. Here you've got the saphenous vein, but you can see that this vein is easily compressible and it's fully compressible. Alright, we're going to begin the exam by placing the transducer in the transverse plane with the indicator towards the patient's right, high up in the inguinal fold. So the first thing you're going to see is going to be the common femoral artery and the common femoral vein. Now as you move the transducer down in this patient's right leg, more distally, you're going to notice that the first vessel to divide is going to be the artery. So you're going to see the femoral artery and the deep femoral artery. You're still going to be seeing the common femoral vein, and you're going to notice the insertion of the greater saphenous vein. This insertion point is important to notice because you want to be able to detect if there is clot burden within the greater saphenous vein about to dump into the common femoral vein. If there was no clot within the common femoral vein, but there was a clot right at this point in the greater saphenous vein, these people should be treated as having a DVT. As you move more distally, you're still going to see the common femoral vein, and you'll notice that there's separation of the femoral artery and the deep femoral artery as the deep femoral artery dives deep. So here we have the right common femoral vein proximal. Again, indicators towards the patient's right, so you're going to have, would be nerve, artery, and vein. Here you've got the transducer in an AP plane in the inguinal fold on the patient's right, and you can see here you've got the common femoral artery and the common femoral vein. And here we are compressing the vein, and you can see that it's anechoic and that it easily and fully compresses. You can see as we move down distally, you can see that the common femoral artery divides first, and you can see then the insertion point of the greater saphenous vein. If there's an area of concern noted when scanning the common femoral vein in the transverse plane, you can turn sagittal in that region in order to better define this area of concern, and if it's a blood clot, potentially look for the proximal edge. Here is just a sagittal view of the right common femoral vein, your anterior, posterior, head, foot, and you can see the vessel right here going from distal to proximal. Now let's focus on the common femoral vein greater saphenous vein insertion. This is going to be obtained by just moving the transducer distally. Remember, as you move the transducer distally, keep it in an AP plane, and what you'll notice is femoral artery, deep femoral artery, common femoral vein, and here comes the greater saphenous vein. Intermittently, you could see that there's a valve at this point here, but this, like I said, is an important view to obtain so that you can see if there's any clot burden within the greater saphenous vein in this region. When the common femoral vein divides, it's going to divide into the femoral vein and the deep femoral vein. And this is the area we're going to focus on next. So you can see here you've got in the near field the femoral artery, the femoral vein, then the deep femoral vein, and the deep femoral artery. The farther you go distally, the deeper the deep system is going to dive. You're going to end up losing that. That's not going to be an area that we're going to be concerned about. We're going to be focusing on the femoral vein here, and we're going to continue to follow that down distally in the thigh. I want to stop for a second to just remind you that this is a danger zone. When you reach the femoral vein, you've got to remember that venous duplication can occur at this level, and in some studies it happens in upwards of a third of patients. And this is important because if you're only looking for one system, you could easily miss an isolated clot burden in one of the systems. So remember, stop at this level and look and make sure that there's not duplication occurring. Normally the veins in the thigh are going to be wider than the associated artery unless they're duplicated. The duplicated veins tend to be smaller. However, this was a patient who had a duplicated system. You can see here's the artery, here's one of the femoral vein systems, here's the other femoral vein system. However, this patient was in congestive heart failure, so you can see that the veins here appear to be equal or maybe a little bit wider than the associated artery. But in general, in a euvolemic patient, with a duplicated venous system, the veins should be narrower than the associated artery, and that may be something that gives you a clue that there's duplication present. Here's a patient with a duplicated femoral venous system. Here we are at the level of the common femoral vein. You can see as we move distally, you've got the deep system and the femoral vein system here. As we move down a little bit further, you can see that there is a second system that appears medial, and this was able to be then tracked as we continue to go farther distally. So keep in mind that femoral duplication is common and you don't want to miss this. Here's a patient with a partial duplication. As we've already gotten here to the proximal SFV, we only see one system, but as we move farther down, you can see that now there are two systems here, and this continued and this was noted to continue as we went farther distally. So keep in mind the duplication does not have to occur right at the spot where the common femoral vein turns into the femoral vein. It can occur a little bit more distally, so just keep that in mind. So to visualize the femoral vein, you're just going to move the transducer down more distally, keeping it in an AP plane, and you're going to end up seeing the femoral artery, femoral vein, and then the deep system. And you can see that here. There's the artery, there's the vein. You can see for a short period of time the deep system before it dives down, but there's the compressible femoral vein. And here's a view of the proximal femoral vein sagittally, so anterior, posterior, head, foot. There you can see the common femoral vein, and here you can see the femoral vein and the deep femoral vein, and there's a valve right at this level here. Here now is the mid-femoral vein, again your transverse, AP, and you can see the femoral artery, femoral vein. Usually at about this level you're not seeing the deep system anymore, but again you're seeing femoral artery, and you can see behind it the easily compressible normal femoral vein. Here we are distal. Again, you're still transverse. In the near field, you're going to see the artery and the vein. At this level by the canal, it's going to be more difficult to compress compress the vein just with transducer compression. So you're frequently going to have to use at this level a two-hand technique where you squeeze from behind in order to document that the vessel does compress and collapse. And here you can see that this was obtained by not transducer pressure, but by hand pressure from behind. Here we're at the adductor canal, and notice that the vein, which is normal in this case, could not be compressed with transducer compression. This is very common when you're down distal by the canal there. You're going to need to squeeze the leg from behind in order to document whether the vessel does compress or doesn't. You don't want to falsely diagnose a DVT at this level based on lack of transducer compression. Here's the same vessel, but we're just using the two-hand compression technique, and you can see that this vessel, which is anechoic, is very easily compressible. Now let's look at scanning of the popliteal vein. This is going to be obtained posterior on the patient's leg. Proximally, you're going to end up with this view, posterior, anterior. You're always going to have patient's right and patient's left. You're going to end up with the popliteal vein in the near field, and deeper to that you're going to have the popliteal artery. You're then going to see the paired gastroc vessels coming off. You're going to end up seeing the lesser saphenous vein insert into the popliteal vein. You'll still see in the far field the popliteal artery, and you're going to continue following that until the popliteal vein divides into the tibial and perineal trunks. Keep in mind, venous duplication can occur at this level too, so don't drop your guard down. Look for two systems. Here's a patient who had a duplicated popliteal system. Here's the artery. Here you've got one system, which is anechoic and compressible, but you can see that there's clot in this second system right here. It potentially, to the novice scanner, it could be easy for you to miss this because you're going to focus just on the anechoic vessel down here and miss this echogenic clot burden within the second system. Here you can see with the patient supine, you've got the leg flexed at the knee and externally rotated, and we're scanning behind the leg here in order to obtain visualization of the popliteal vein. And here you can see we're following the vessel distally towards where it ultimately divides, and this is where the exam is going to end. Here you can see the paired gastroc vessels. You can see the lesser saphenous, which is ultimately going to insert into the popliteal vein, and you can see that here in sagittal. You can see there's the lesser saphenous vein, and here you can see it coming into the popliteal vein. This is a sagittal view, so this is going to be posterior, anterior, head, and foot. So just like with the greater saphenous vein, you want to be looking at the lesser saphenous vein to see if there's any clot burden right at this insertion site, since somebody who has a clot burden in the proximal lesser saphenous vein should be treated as having a DVT. This concludes the Performing the Lower Extremity Compression DVT exam video.